Our next presenter is Jialin Mao. Jialin has an MS in epidemiology from the Harvard T.H. Chan School of Public Health and earned her PhD in epidemiology from the Columbia Mailman School of Public Health. Jialin is an assistant professor at the Department of Population Health Sciences at Weill Cornell Medicine, is one of our investigators within our Center for Social Capital, which is a U54, NCI-funded U54 center that is a tri-institutional partnership between SUNY Downstate, Columbia University, and Weill Cornell Medicine. And Jialin will be presenting on healthcare segregation among colorectal cancer patients residing in high poverty areas. Thank you, Jialin.
I know you must have a lot of questions about this title. I hope that comes clearer as I walk through this work. So I first would like to thank the SOCA Center, which supported this study through a pilot grant. And as Marlene mentioned, SOCA is one of the 5 persistent poverty initiative centers founded by the NCI. And just a brief background. Colorectal cancer is has the third highest incidence and third highest mortality among both nationwide and in New York City and in New York State, sorry. And for colorectal cancer diagnosed at non-metastatic stage, the primary treatment is surgery. Some patients with more advanced stage cancers, they might get neoadjuvant or adjuvant therapies, but for most of the people, they get surgery. And that's where this study is focusing on. So why do we want to look at area level poverty? I think if you look at these two maps, on the left, it is cancer mortality rates by county. On the right, this is a map of poverty rates by county. And for the majority of the country, in the areas where you find high cancer mortality, you can also see there are counties with high poverty. And that's where some study has shown that if they look at patients living in high poverty areas, by high poverty, we mean areas where 20% or more residents living under federal poverty. This study, they have defined high poverty area based on the duration of the of poverty for each county, and they found that regardless of the duration, patients living in high poverty areas, they had higher colorectal cancer specific mortality than those living in non-poverty areas. And so now that we are speaking about disparity, I just want to say a few words about the terminology. I think for the majority of the part, we all agree that that disparity refers to some sort of differences in health and healthcare among population groups. So, for example, the difference in cancer mortality rates that we see by area level poverty is a disparity. And inequity tend to have quite different definitions from different sources. And I do want to focus on one of those in this presentation, is that it refers to some forms of injustice or unfairness, which is closely related to disparity. And to some extent, it might be the driving factor of disparity. So my study question really came from a lot of the observations from my past work. Before I did my PhD, actually, I did a lot of work in surgical outcomes research. I still do some work in that part. And then I have just repeatedly seen that patients from low poverty areas, they were more likely to be treated by low volume hospitals or hospitals with low technology use or non-cancer accredited centers. And there had been extensive study related to patient outcomes associated with these cancers with these centers. And most of them have consistently found that patients treated by low volume, low technology use, and non-accredited centers, they had worse health outcomes than those treated at the counterparts. And you can see that, as I said, in surgical literature, a lot of the times, you can see that people study area level poverty, or more broadly, the neighborhood socioeconomic status, as sort of a covariate or a characteristic of patients. They look at it as a predictor, as a risk factor. But as a public health researcher, I'd like to do it the other way around. I'd like to actually look at the disparities between patients from high poverty and low poverty areas and dig into what contributes to that. And so that's where my hypothesis came from, is that we obviously see that there could be some differences in their treatment location. Is that one of the reasons that could explain part of the disparities between in short and long-term outcomes between these patients? And there are conceptual frameworks that support our hypothesis. This conceptual framework proposed by the Centers for Population Health and Health Disparities, they looked at factors contributing to disparities from proximal to distal factors. By proximal, we mean biological or individual level factors such as genetic disposition or individual behaviors or age comorbidities. By distal factors, we mean social conditions or health system level factors. And they propose that these are actually can be considered fundamental causes of disparity. And so my study question was, can we try to characterize where patients from high poverty areas receive colorectal cancer surgery? If so, can we try to quantify the impact of treatment setting on disparities in health outcomes? And then lastly, can we try to assess some of the characteristics of these hospitals? So from there, we can see if there's any common characteristics of these hospitals, if there's something we can do about it. Our data source is SEER Medicare data, which many of you might be familiar with. SEER Cancer Registry collects cancer characteristics. The participating states of SEER tend to vary from time to time. And in this linkage we had, it covered about 14 states. And then the longitudinal linkage to the linkage to longitudinal Medicare claims really enabled us to look at patients' comorbidities, the treatment they get, the treatment characteristics, where they get the treatment, and the providers who provided the treatment. Our study population was patients aged above 65 years, diagnosed with non-metastatic colorectal cancer, and received surgery within 6 months of diagnosis. They had to have continuous fee-for-service enrollment 1 year before the surgery for us to look at their comorbidities. And our area-level poverty measure came from county-level poverty derived from census and American Community Survey. We did look into if we can actually look at census tract level poverty, but it turns out for the duration of our pilot study, that was not possible. So we had to use the county-level poverty. And it does have some limitations, which I'll come back to later. And high poverty area is defined as an area with 20% or more of its residents living under federal poverty. That could include persistent poverty area, which is a high poverty area for more than 30 years, or current poverty area, which is a non-persistent poverty area, but a high poverty area for the year of the diagnosis. Our health So when we are trying to look at what hospitals treated patients from high poverty areas, we try to characterize it from our data by calculating the percentage of patients from high poverty area getting treated at a certain hospital. And we did somewhat an arbitrary cutoff at 50%, where we define if a hospital treats more than 50% of patients from high poverty areas, then we consider it a poverty area serving hospital. Our health outcomes was in hospital adverse events and 30-day readmission, but these two were short-term outcomes. In hospital adverse events is a composite of death, medical complication, and procedural complication. And our two long-term outcomes were all-cause mortality and cancer-specific mortality. So to look at the impact of treatment location on disparities on health outcomes, we came in with this hypothesis that if we look at patients from low poverty area treated at non-poverty area serving hospitals as a reference, we hypothesize patients from high poverty areas, regardless of where they received care, they are going to have slightly worse outcomes because of the contextual effect of poverty. And it is the group of people who were from high poverty areas and treated at poverty area serving hospitals. They're going to have the worst outcomes. And lastly, for looking at hospital characteristics, we synthesized data from a few sources. One is the hospital file that came with SEER Medicare, which collected data from healthcare cost report and the provider of service survey. And from there, we got the geographical location of the hospitals, its NCI designation or Commission on Cancer accreditation, and staff to bed ratio, which we counted both nurse and physicians. We also derived some data from the claims as well as Medicare data on provider practice and specialty file, and we derived annualized surgical volume, which is considered a quality indicator, and the use of the capacity of robot-assisted surgery, as well as the presence of colorectal specialty surgeon. Our cohort included about 81,700 patients, of whom 15% resided in high poverty areas. And we can see that patients from high poverty areas, they tended to be younger. A larger proportion of them were now Hispanic, Black, and lived in urban or rural areas. So moving on to the first question, can we characterize the hospital that predominantly treated patients from high poverty areas? So it turned out we could. And we found that we had about 991 hospitals in our data set, and of them, 18% of the hospitals, they predominantly treated patients from high poverty areas. And these hospitals, they treated about 64% of patients from high poverty areas versus 3% of patients from low poverty areas. And that phenomenon basically existed across metropolitan, urban, and rural areas. And I know these numbers are a bit hard to wrap your head around, so I made some minuscule figures. I had one mini hospital standing for 100 100 real hospitals, and one mini person standing for 500 patients. And it was about 2 in 10 hospitals were poverty area serving hospitals. And those 18% hospitals, they served 64% of the patients from high poverty areas and only 3% from low poverty areas. And that's where I want to talk about this terminology of healthcare segregation from my title, is where we found these hospitals, they predominantly treated patients from high poverty areas, where very few from low poverty areas seek care there. And that shows a pattern of segregated care. And so what's the impact on the outcome? So for the majority, it really aligned with our hypothesis that it is this group of patients who were from high poverty area treated at poverty area hospitals, they had worse outcomes. However, you have to know for most of the outcomes, this group of patients didn't really align with our hypothesis that they are going to have slightly worse outcomes, those who were from high poverty areas treated at non-poverty area hospitals. And we think that has something to do with the limitation of using county level poverty, because especially in metropolitan areas, a county can be a very diverse geographical area. Brooklyn is considered a high poverty county, but Brooklyn has a diverse set of neighborhoods. Some of the neighborhoods are really well off. And so this group is really capturing some people in a high poverty county, but then they lived in a better off neighborhood. And the reason why we think this is the case is because when we did a subgroup analysis by metropolitan, urban, and rural areas, in the urban areas, we actually see this group moving closer to our hypothesis, because as I said, in metropolitan areas, the counties can just be very diverse. While when it comes to urban areas, the counties tend to be a bit more homogeneous. So for most of the part, the results from the subgroup analysis by racial ethnic groups, as well as by urban rural areas, they were consistent. The only thing is that we didn't really observe any impact of the treatment location on the health outcomes by different poverty areas, by poverty or high poverty or low poverty areas, mainly because this subgroup was very small. And also there could be some difference in terms of when you're residing in a rural area versus when you're residing in a urban or metropolitan area. And then for Hispanic population, we did see a larger magnitude in the increase of long-term mortality among patients from high poverty areas treated at poverty area serving hospitals. So moving on to the characteristics of these poverty area serving hospitals. So first we looked at the geographical locations. A larger proportion of hospitals in the South, in rural areas, they were more likely to be high poverty area serving hospitals. And when we looked at a few resource-related factors, we found that hospitals with no colorectal specialty surgeon, with lower volume, with no capacity for robot-assisted surgery, low staff-to-bed ratio, as well as no cancer accreditation, they tended to be more likely to be poverty area serving hospitals. These results, I would say, probably are not surprising. At least it wasn't really surprising to me because it sort of confirmed anecdotally what I've heard. It was good to actually pinpoint them and put them on the paper. And we didn't run a multivariable logistic regression here. As you could imagine, a lot of these factors, they are very, very intercorrelated. So we tried to use a non-parametric method, classification and regression trees, to try to see if we can characterize some subgroups of hospitals that are very much likely to be poverty area serving hospitals. And this is what we found is that for this group of hospital, which are rural South, with low staff to bed ratio, 3 in 4 of them were poverty area serving hospitals. And then for rural South, thank you. Rural South hospitals with medium to high staff to bed ratio, but if they are government hospitals, they were also very much likely to be a poverty. They were also just a lot of them predominantly serve patients from high poverty areas. So just briefly summarize, we did find a group of poverty area serving hospitals that treated mostly patients from high poverty areas versus very few from low poverty areas, and which I call it the phenomenon of healthcare segregation. And healthcare segregation by area level poverty did have a negative contribution to the disparities in short and long-term outcomes. And we did look at the characteristics is that a larger proportion of low resource hospitals located in the rural South, they were poverty area serving hospitals. So we were contemplating a bit about why we find differences in the outcomes for both long-term and short-term outcomes, because for the short-term outcomes, there's a lot of literature reporting on the effect of, for example, low surgical volume or low use of technology has a negative impact on health outcomes, for example, complications. So that could, for the majority, explain why being treated at these poverty area serving hospitals led to worse short-term outcomes. But then when we thought about long-term outcomes, our hypothesis was that when patients got treated at these hospitals, it is sort of like it symbolizes what kind of healthcare resource they have available in their dispersal. And then it's not just about surgical quality, it could also be about the availability of multimodal treatment, multidisciplinary care, the use of proper adjuvant therapies or appropriate long-term follow-up care. So this is the part that we wanted to actually explore more and have some ongoing work for that. So coming to here, now we need to think about where does this lead us? So we found that there's healthcare segregation by area level poverty, and we found that it contributed to disparities in short and long-term health outcomes between patients from high poverty and low poverty areas. And as we're talking about clinical trial representation today, I would also hypothesize that this could have something to do with the clinical trial representation, because if patients are treated a lot of the clinical trials are just run at tertiary centers. If patients are not treated there, they're going to be much less likely to receive information about clinical trials. And so like, can we do something about it? I think a lot of the times traditionally we have been thinking about like, how do we make the information flow to the patients? How do we provide more education for the patients so that they can have better access of care? But I would argue that this is important, but this is not enough, because not only does this place a lot of burden on the patient side, it also is not realistic to some extent. Like, for some patients living in more rural areas, they go out and there's only one hospital within 2 hours of drive. What do you do? Do you tell them to go to a better hospital? It's not realistic. And for some patients, when we were talking to community members through the SoCal Linking Group, and community members mentioned that there might be insurance coverage issues. There might be preference that they prefer to be treated at a local hospital, which treated their families and family members and relatives or friends. Or sometimes they feel unwelcome at some hospital and they feel more comfortable at certain hospitals. So individual resources are important, but it doesn't necessarily address all of the things that need to be addressed. And so I would propose to look at more collective level resources, which could include societal level resources, such as how do we distribute care resources so that when you have a rural hospital and they have adequate resource to provide care for patients, or community level resources, when you can try to link their resources available in the community, how do we try to link up people to those resources? And then also there's the interpersonal level factors. Can we try to make the resources flow between individuals such that it creates a group level synergistic energy to make things better, to make their care better? So here I really like the SoCa framework of bridging, bonding, and linking. So bridging is how do we establish resources in the community. Linking is how do we link those resources to the individuals. And bonding is how do we link individuals and make the resources flow between them. So that's where I want to go next. And obviously, if any of you are interested in working on any of these pieces, just please feel free to contact me. Thank you.